Well, thank you again, everyone, for joining today. I'm going to go ahead and get going here on our Corneal Topography course. I just want to express again my gratitude for everyone for attending today and taking your time to be with us. It's been fun so far, and I hope we get some good feedback. If you do have any feedback, just in the same way that you can request your certificates, if they don't come, feel free to respond to one of these emails, which will go to Kayla@wingvisioninstitute.com, because we would like to know what you liked about this, what you didn't like, etc. Okay. But on that note, I have no financial disclosures here. And then I did want to go over several different things about corneal topography. So topography is something we use daily here in a surgical setting, both for medical use, which is what we're going to focus on today, perioperative use, and then of course there's good benefits for vision use like contact lens fittings. So first we're going to start by talking about the basics of corneal topography. Just in general, a quick review of corneal anatomy. The average anterior corneal power is somewhere in the neighborhood of 48. The average posterior corneal power is in the neighborhood of -7. So essentially that gets subtracted, the majority of the posterior corneal power, not all of it, but a portion of it, and results in an average cornea curvature or power around 42 to 44. Over time, the cornea does flatten by age 30 during early growth, and then it actually steepens over time by 1 diopter into adulthood. Young adults tend to have with the rule astigmatism, which shifts to against the rule astigmatism later in life. And these are representative topographies for both of those. So the with the rule and the against the rule astigmatism here. The normal corneal shape is prolate, which means it's steeper in the center and it flattens to the periphery, so that we have the example representative image on this side of the screen. Oblate shape is common after myopic refractive surgery. So the cornea actually flip-flops and becomes flat in the center and steeper in the periphery after myopic LASIK. Corneal thickness. Some topographers that we'll review do provide information about thickness of the cornea. The average central thickness of the cornea, as we know, is around 550. And this provides information about it in different quadrants. So temporal, we're around 590, nasal 610, inferior 630, superior 640. The thinnest site is located about 1 millimeter from the visual axis inferior temporally. So what is topography? So this is actually the definition directly from the Center for Medicaid and Medicare Services. Computer-assisted diagnostic imaging technique in which a special instrumentation is used to create a color-coded map of the corneal surface as well as a cross-sectional profile. The service is used to provide a detailed map of chart of the physical features and shape of the cornea. Obviously, we use it for many different things, but detection of surface irregularity and astigmatism. Looking at corneal maps, there are different ways to go about it, and that's what we'll spend the next few minutes looking at. There is what's called an absolute scale, and that means that the same color is used for different steps. Ultimately, each cornea then would be applied the same range, meaning that maps can be compared directly as the same scale would be applied across. The disadvantages, though, is it doesn't show subtle changes of curvature and sometimes could miss early keratoconus because that may be too subtle to show up on the absolute scaling. Normalized, different color scales are assigned to each map, and that reflects the minimal and maximum curvature of each cornea. This is great for viewing a single scan in detail. However, the big disadvantage is that two different maps cannot be compared directly. So Ks from different color scales must be compared. Most topographers use what would be considered absolute or standard scaling, not normalized as default. There are different map types, as everyone's aware. We'll go over the major maps. There's even more than this depending on the topographer, but these are the major ones. Axial and tangential maps, elevation maps, and thickness maps. Axial maps are often called sagittal. It averages the data to create a smooth map. It can miss details in corneal shape. It's more accurate for central data than peripheral. The advantage is it does provide a good overview of the corneal power, and the disadvantage is it can miss minor variations. So in this upper right corner, this is a map of a patient. As we can see, it looks fairly regular and fairly uniform on the axial, but if we switch over to the same patient on tangential, there's actually a lot of local irregularity that's noted. So this could be a patient with epithelial basement membrane dystrophy or something along that lines. Tangential maps are often called meridional, instantaneous, or local. They represent the local curve at each point relative to the other points. The advantage of these is they can recognize sharp power transitions, and they're more sensitive to small changes. The disadvantage is there's a higher degree of variability from point to point. I'm going to try to put this in more easy to understand terms in a few slides. Elevation maps reference corneal data to what would be considered often a best fit sphere. The deviation is displayed relative to this reference shape. Warmer colors are higher than the reference. Cooler colors are depressed from the reference. So certain topographers that show posterior elevation changes, like this example in the upper right corner, can be used for keratoconus and other things. So elevation maps can be both anterior and posterior. They're often viewed as providing the truest shape of the cornea, but the important thing to know is they define the corneal shape, not the refractive power, unlike the axial and tangential maps. Thickness maps, these are available on instruments which evaluate the posterior cornea. They give information about distribution of corneal thickness, so it's often much superior to what you can obtain from simple pachymetry. Useful for glaucoma, very useful for refractive surgery, and of course for corneal ectasia like keratoconus. So I do want to provide kind of real world-ish or demonstration purposes of what an axial map is in some terms. So if we have an irregular shaped cornea like this patient that has undergone RK, they may have quite a few bumps on the cornea. An axial map would take somewhat of an average of these bumps, smoothing out some of the highest peaks like this one here, maybe leaving out some of the lowest valleys like this. If there was a hiker walking along this axial map, it's pretty easy because it's a smooth transition from one to the other. And this would be an example of, though, a highly irregular cornea. This patient has had radial keratotomy. So the incisions I'll kind of trace with my mouse can be seen here, ultimately showing significant irregularity and variability throughout the surface. In contrast, tangential, it shows more the very precise points, so it doesn't average the data much. So the hiker would have a much harder time hiking this. And as we can see, this is the exact same cornea. We represent this actually with two different types of topography. And the pattern, as we can see, is much more diverse. We see a lot more detail. It's a lot more abrupt changes, more, ultimately a little bit more data when it comes to it. So axial here shown again versus the tangential maps. Same cornea, just the different map. Same scan, exact same scan in time, just a different map. Elevation, This same instance, we would fit the cornea with a spherical shape approximately, where about the same amount of cornea would be referenced above and below the shape. Colors that are represented below are cooler. Colors that are represented above are higher, which results in a map like this. So the incisions are slightly depressed from the average cornea, which I'm tracing with my mouse, versus the peaks between the incisions that are showing here, like this big peak here. And this is anterior elevation map, so that's very important. We're going to kind of take this more theoretical and go underground. Let's imagine these mountains have a very big cavern underneath. Posterior elevation is pretty similar to anterior, but the reference shape is just going to be in reference to the posterior cornea. So I'm going to trace what would be the posterior cornea on this, which would be kind of where these caverns start. Ultimately, same thing. The colors below this would be cooler, and the colors above would be steeper. For patients with RK, usually they're not too ectatic or too irregular on the back surface of the cornea, because that structure is normally fairly intact. So it doesn't show much irregularity. There aren't usually two sudden abrupt changes, though there is one showing up here. A normal cornea, this curve would fit almost exactly with the cornea, so it would have no significant elevation. But a keratoconic cornea, there would be a significant change between the anterior surface of the top of the mountain and the bottom surface, the bottom of the mountain, or the start of the caverns or whatever, ultimately, which would show a big elevation. So we'll show you a bunch of maps of keratoconus, and that may make a little bit more clarity. And then finally, thickness, pretty straightforward, no fancy images here. It literally just would measure the thickness of the cornea. So similarly, this is the exact same cornea through all these, just the different maps. And cornea thickness is normally pretty uniform in patients who've had RK, unlike keratoconus. So I do want to do a poll here. Oops, possibly. Yep. So I'm going to go ahead and launch the poll. And the poll here would be, which type of map affects your clinical decision-making most in your practice setting? So axial, tangential, elevation, anterior, elevation, posterior, or thickness. And this is a very hard question to answer because these are all important maps. But if you had to pick just one, and I kind of had a feeling about what this was going to show, which will be interesting to show everyone. And I hope this course will be useful for patients that may not have access to a topographer, because it does look like that's a lot of our attendees here. We'll give it a few more seconds for that to come on in. All right, we're going to end it here. So the most common answer was sharing that. I don't have access to a topographer, which is what I kind of had a feeling. Prior to me starting at Wing Vision, I made very minimal use of topography. And then the second most common was axial, which I kind of agree. Those are the most common maps reflected for refractive surgery and other things, the most commonly used maps. Though these other maps, particularly posterior elevation, can be helpful in keratoconus settings, refractive surgery settings. All right. And one really important thing, and Tracy touched on this earlier, scan quality is easily affected by tear film. So one really huge thing is it can vary from blink to blink. Other things that can affect scan quality include position of the eyelid. So if the lower or the upper eyelid is drooping down, it can really cause alterations in the way the topography can look. If the eye is moving, that's even more specific for certain types of topography that we'll talk about, and the different positions of gaze. So if the patient's not looking straight ahead. If there's any issue with scan quality suspected, then repeating a scan is very important, and I'll show examples of that. Also, sometimes you really can obtain a topography, or you can obtain a reliable topography. And in this case, you really need to treat these patients aggressively for dry eye and then bring them back for topography another time if it's critical for decision making. Examples would be like prior to cataract surgery with the toric IOL. So examples of scan quality here. This is the same eye, 3 different scans. Very important, this patient has undergone hyperopic LASIK, so we do expect a very significant steepening in the center. When I look at these, there's one that's just totally unreliable, and I would say 2 that are fair. I personally grade this one being the best. It shows the most symmetry, which is kind of how I usually choose. Least abrupt changes in the cornea. Like this one that's fair, there's an abrupt change that doesn't seem likely to be anatomical. The only thing about this one, even the very best scan still has a missing scan area, which is represented by this black box. So in an ideal setting, we would actually repeat these again. And then this is the patient's right eye. There's not nearly as much variability. There's one scan that I feel to be an outlier, which is this one. The others look pretty similar. However, I'm seeing more symmetry with the middle one, more uniform bow tie shape versus somewhat irregular here. And that's how I can try to pick and choose which are the topographies to keep or to use for surgical purposes or other purposes. And then very important for patients who may be undergoing cataract surgery with the intent of getting out of glasses, like Tracy had touched on earlier. Ultimately, if the surface of the eye is dry, it can cause significant changes in the Ks, which would be reflected both on the topography and the biometry, like the IOL master. So treating those patients is very important prior to having them undergo surgery. I want to briefly go over the different...
Dr. Rock, there's a question about that. Do you add a re-wetting drop prior to taking the scan?
Oh yes, I'm so glad that you someone brought that up, because that is a little controversial perhaps, but definitely if you're having trouble getting the scan, do put re-wetting drops in. That's the thing you want to try before sending the patient home, certainly. Now, I have heard there's certain people who say, well, don't put drops in routinely, because if patients do have significant altered topography, you might want to consider treating their dry eye prior to whatever you're planning. So usually we advise to put the tears in if the topography looks irregular, and our technicians are pretty trained for that. But if not, we'll send the patient back. Great question.
And there's one more question. For those of us who have limited topography experience knowledge, would you advise focusing on the axial map for LASIK/refractive surgery consults? Will that be able to rule out suspects of keratoconus pellucid post-surgical ectasia?
Yes, a really, really good question. So generally, the axial map should pick up even fairly subtle changes. Some sources say that tangential actually overdiagnoses or like overly would raise your concern level for keratoconus. So usually the axial maps are sufficient. And if the patient has a good axial map and a good corneal thickness and nothing else raises red flags, some centers find that to be okay for refractive surgery. Having the posterior data, which we'll go over in just a moment, is very helpful, but it's not absolutely necessary. So yes, the axial map is very helpful for that. And I would say the preferred map for what a lot of us have in our offices.
That's it for now, thanks.
Perfect. So we're gonna go over these different types. Most of us should be familiar with the Placido ring topographer. So it's based on an overlay of concentric rings that are projected onto the corneal surface. If the Meyers are closer together on the analysis, then the cornea is steeper. If the Meyers are wider apart, then it's flatter. So the system contains a transilluminated target that's reflected onto the cornea, an imaging system that captures that image. It's analyzed, and then it spits back the topography. So that's how they work. Different examples here. There's many, 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 and this is not a complete list, but it's a pretty good list. So a large cone would be like this one here at the bottom, where the cone that's projected on the cornea is very, very big. And then small cone, which I know we're losing our reference, but this is only maybe a few inches across or even less, versus almost like a maybe 8 to 9 inches across for this large cone, and maybe 1 to 2 inches for this one. They work on the same principle. The large cone are easier to obtain because they don't have to get as close to the eye, but because they are further away and larger, they're more prone to variability. So the small cone are harder to obtain, but because they can get a lot closer, some people consider them more accurate. So those are those examples. And then there's the slit scan imaging, which is a topography that uses slit scanning optical design. So it's similar to what we would use as like a slit on our exam. It captures then 40 different slits at a 45-degree angle, so really imaging the entire cornea. The software analyzes the points. It calculates then pachymetry and the posterior corneal surface. As far as I'm aware, there's only one topographer that works off this principle, which is listed here. And then finally, two more, the Scheimflug imaging. It's a rotating camera that measures images of the anterior corneal surface all the way back to the crystalline lens. This Scheimflug principle is a geometric rule that looks at how orientation of planes to focus from different systems, and ultimately includes then a very detailed map of the cornea, both anterior and posterior data, just like the slit scanning design here. It works on a different principle, but provides a good wealth of information. There is another corneal topography type that's pretty unique called the color LED dot system. So this topographer uses a point-to-point mapping of 700 dots that are projected onto the cornea. It's similar in some ways then to Placido, but it's by some considered to be a little bit superior because the points, they can be extrapolated a little bit better than the rings. It can also be combined with Purkinje, and it actually looks at the second image on the posterior cornea to estimate the posterior surface. Not quite as accurately as the prior two devices that measure it, but it is available. Some benefits, are the fact that the dots may increase the precision versus the rings once again. And as far as I know, just one example of that one. So perfect. We already know that a lot of us don't have access to a topographer, which is what I was expecting. But if you do, I'm going to have us vote in poll 2. And if you don't, so we can get some representation, just out of curiosity. All right, well, this is a marathon. If anyone's been with us since 10 a.m. Central, this has been a fun event, I think, but it's definitely not a sprint. This is a marathon. In fact, you can run a marathon in less time than these 5 hours. But it's been fun, and I appreciate everyone making it again. We'll give about 15 more seconds, and then I'll close this one. Okay, awesome. So I'm going to share this, and very similar to what I was expecting. So actually about 44% of participants here don't have access to a topographer, which is perfectly fine. You can always involve centers that do when you need. Refer to your own colleagues is a great way to do this. Another optometrist, in my opinion. Other popular ones here, though, the Placido is what I suspected, and then the Scheimflug, which is also very popular. I'm fortunate I have access to several different types, which I know is very uncommon. I know most places will just have one topographer available. All right. So then we'll jump into the medical indications for topography. So the big focus here is what can you use corneal topography for, and kind of how can that benefit the practice from diagnosis and productivity standpoint. This is directly from CMS. So corneal topography is considered medically necessary for any of the following conditions. So big ones that you might not consider would be like monocular diplopia, post PKP, corneal dystrophies, of course, keratoconus, of course, pterygium. But ultimately, it's not only things that you'll think of, and we'll go into this a little bit further. Also, topography is incredibly important, of course, for refractive surgery. So LASIK, other corneal surgeries like SMILE, PRK to rule out ectasia. Very important for planning for astigmatism correction during a lens surgery, you know, special for like limbal arcuate incisions, whether those are manual or laser created, toric lens planning. It is really helpful, and most surgeons that do premium IOLs will use both the biometry, like an IOL master, and the topography, because they're different technologies that are complementary. You don't really get the full information from either one. And of course, for vision indications, just like Tracy was saying, this is an area I have less experience with, which would be a specialty contact lens fitting. But of course, very, very necessary to have a good topographer for fitting a lot of these lenses like the scleroils, and particularly for orthokeratology. So that brings us to our third poll. All right, and this would be, what do you use topography for most commonly in your clinical practice? All right, I'm gonna close this one here any minute, though I'm still getting a bunch of responses, so. All right, 57% participation rate, that's pretty good. And let's share these results. So like we've seen in the other polls, most people don't have access. As I was expecting and hoping, actually, vision indications like contact lens fitting was the #1. And I have a lot to learn from y'all, and I hope you can learn something from my presentation about the #1 and #2, which is the medical and surgical side. Okay. So billing and coding, just very brief. The CPT code is listed here. The 2018 fee schedule is about $40. And just like any test, you have to include appropriate documentation to justify your test. So nothing out of the ordinary, nothing different than what you would include for any other test, but good to take a look at that as a review. These are specifically listed under the Center for Medicare and Medicaid Services as acceptable codes to use for topography. So this is not an all-exhaustive list. You can certainly get things covered that aren't on this list, I know for a fact, but these 100% will be covered. And I wanted to cover some things that you may not consider using your topography for in your office. So if a patient has a corneal scar, that's a justification for doing a topographer. Obviously corneal dystrophies and keratoconus, so I did not highlight those. And then another big one is diplopia. So if you suspect monocular diplopia, and I'm super guilty of this, I'll often not even consider doing a topography, but that can be super helpful, and it is a covered diagnosis that you can use that code, diplopia. So just things to consider. Consider ways to best serve your patients and make use of this technology should you have them available in your practice. So this list, once again, is directly there. There are other codes that could be covered. And then specifically what's not covered would be, astigmatism, unless it goes along with an accompanying code like corneal transplantation or filtering surgery like after glaucoma. So, generally you can't code specifically for astigmatism unless it goes along with another code, in which case you can just use that code in and of itself. So non-covered services are very important. It's not covered prior to refractive surgery, so it's never submitted. And then it's not covered for routine use prior to cataract surgery unless there's another diagnosis like corneal scar. So it cannot be billed when used solely for toric IOL or astigmatism correction planning. We do this on our patients at Wing Vision just to get the best feel for what their cornea is, to know how we can best serve them. But it's essentially a complementary service. Unless there's a significant issue, in which case I would educate the patient using their topography and then consider billing for it. And we'll go over that. So now I wanted to jump into a few cases that demonstrate how to use topography and some other pearls about topography. This case is a 39-year-old male whose concern is blurred vision in the left eye. Ultimately, the visual acuity in the right eye is good with minimal prescription. In the left eye, there's a significant amount of astigmatism. I bet someone could figure out, without even knowing what the topography is, where we're headed with this case. And if someone wants to throw it in the chat box, Marianne can read it off. But I think it becomes fairly clear here on the topography. So the right eye shows a very, very uniform surface of the cornea, mainly looking at the axial map as we had discussed some earlier. The posterior elevation is helpful to look at with this, which is the Scheimpflug technology. But then on the left eye, there's a very, very, very significant irregular astigmatism. On the nasal cornea, a very significant area of flattening, which I'm highlighting here with my mouse. And ultimately, I'm sure just about everyone in the audience would guess what this one is. I didn't do a poll, but it is a pterygium. So visually significant pterygium. The patient underwent pterygium surgery. I wish I would have I need to get a topography of someone who has undergone for comparison after, but it does regularize the shape, though it's never going to be like that right eye again, unfortunately. This patient, the topography can be billed. It's linked to the diagnosis of pterygium. But these topographies can be very helpful. This case is an extreme case. It's obvious that the patient is having vision issues. If you look at this cornea, you can understand why. Even though the patient is 20/25 here, with this much irregularity going on, that is not a good quality 20/25 by any means. The topographies can be helpful when it's a much more mild pterygium, especially if the patient is symptomatic, because sometimes these can look a little bit more extreme than you might not consider. So always, if you do have one in your office for a pterygium, run that topography before you send them over to a corneal specialist if you're on the fence. And then the second case is a 48-year-old male who's interested in refractive surgery. So a very high myopia and moderate astigmatism. Patient's 48, so they're presbyopic. This is the topography. So the topography shows a significant amount of corneal astigmatism. So that's most important for often for refractive surgery considerations. And then also we get the thickness information, which shows the cornea is very thin. So we're looking at in the 400s. The features, once again, though, are the cylinder amount, which is very high on the topography, right around 2 in both eyes, and then the thinner than average pachymetry. So for a 48-year-old patient, we can pretty much already rule out with this high amount of prescription any sort of corneal surgery. This patient did choose to undergo refractive lens exchange with a trifocal IOL. That should say trifocal. And it was a toric. So ultimately, with this amount of astigmatism on the cornea, they needed the toric variety of this IOL. Furthermore, at day 8, the patient is super happy with the right eye, but they're noting blurred vision in the left eye. The right eye shows minimal prescription. The IOL is in good position inside the eye at around 82, which corresponds to the topography map, versus the left eye, which the vision is 20/50. There's still 2 diopters of refractive astigmatism, and then the IOL is aligned at 143. So I'm going to add some lines to show this. If the IOL is congruent or in line with the steep meridian of the cornea, then the patient's going to see well. If the IOL is out of line with the steep meridian of the cornea, like the left eye, then the patient is not going to see well. Ultimately, this one the left eye needed a toric IOL rotation. You can do rotation purely based off of the topography, but we will also use a really helpful tool, which is stigmatismfix.com. And I probably should have written that right on here, stigmatismfix.com, which is something you don't even need a topographer to do. You can, you just type in essentially the patient's current refractive error and then the current position of the IOL inside the eye as estimated at the slit lamp. The way you would estimate the IOL position is by turning the beam on your slit lamp to rotate it, just like you would look at like a toric contact lens. And it spits back how much the lens needs to be rotated. If this agrees with the topography, then we don't hesitate and we get the patient scheduled for a rotation. If this does not agree with the topography, then we hold off on rotation until we can stabilize everything a little bit more. So we did choose to rotate this IOL. It was very clear from the calculation as well as the mismatch from the plan that they needed the lens to be rotated. 1 day after rotation, so post-op day 1, the vision returned to 20/25. The refraction was plano. I'm not making that up. It's really from the chart. And the IOLs oriented right around the steep meridian. So they're in line, they're congruent with one another, and the patient's happy again. This is something that we do commonly in refractive surgery setting, but it cannot be billed because it's used for refractive surgery. Case 3 is a 39-year-old female, blurred vision in the left eye, worse than the right eye, and it's getting worse over time. This is another one you don't need a topography for, but it's helpful for certain things. So just with this information, I think most people can get the diagnosis. So very, very high amount of myopia, significant amount of astigmatism, and poor best corrected vision with glasses. So 2100 in the right eye, 2200 in the left eye. The vision improves significantly with the hybrid contact lens. So there's no question this is some form of corneal ectasia, keratoconus. Ultimately, features of this are going to be the inferior steepening here on the anterior surface, elevation on the back surface. So where the cornea is the thinnest, it's showing the most abrupt change relative to the anterior surface. So that results in a significant elevation showing on the back. And that's helpful for diagnosing early keratoconus. And I'm trying to circle that with my mouse. And I'm doing it wrong because that's the front surface. So it's going to be very elevated, the cone, of course, on the front. And then also the elevation on the front cone will match the back. My apologies. So this is the front surface and this is the back surface, which normally we're going to mirror one another in keratoconus. Also on the left eye, a very similar significant inferior steepening, elevation on the front where the cone is, and elevation on the back where the cone is, because that's where the cornea is very thin. So there's being an abrupt change in curvature from the anterior to the posterior surface causing that elevation. And then we can watch over time. So this is the 2017 topography, and then this is the 2019 topography. It can be a little bit subtle, but on these maps, we are seeing an increase in the bright red steepening on the axial map specifically. Elevation map is worsening as well. The thickness map is decreasing as well. So all those things are very important to look at when we look from one to the other. But a big thing would be the steep Ks increased by 1.8 diopters on the right eye and 1.3 diopters on the left eye. For case 3, we decided to stabilize the cornea with both intacts and corneal cross-linking. This can be submitted, of course, with a diagnosis of keratoconus. We usually will definitely perform cross-linking on all patients with ectasia that are symptomatic, and if they're progressing, insurance usually requires at least some mild form of progression to cover. And then for patients with a poor best corrected visual acuity, intacts, because it regularizes or improves the regularity of the shape of the cornea, can help to improve the best spectacle corrected vision as well as reduce the curvature of the cornea. So after the intacts and cross-linking, the cornea is a little bit more regularized. The cone is a little bit smaller, and the steepness is reduced. The steep K, 1 diopter in the right eye, and about 1 diopter in the left eye here. So we can flip back. This was the map prior to surgery. This was the map after surgery. Okay. So I did want to go over keratoconus staging. There are several classification systems, and believe it or not, there's not a real consensus about what the best one is, but this Amsler-Kremlich classification system is probably the most cited, which is graded only on a purely numerical form from 1 to 4. I added in myself the mild, moderate, advanced, severe. That's not directly in there. But the big things from a topography standpoint would be for stage 1, it's central K readings less than 48. For stage 2, it's central K readings less than 53, so between 48 and 53. For stage 3, it's central K readings greater than 53, 53, excuse me. And then for stage 4, it's central K readings greater than 55, and that's the mean keratometry. Another way of classifying keratoconus is based on the shape of the cone. So there's 3 shapes that are often described: the central cone, which is often called nipple cone, the oval cone, which is sometimes called sagging, and the global. So central is, these are representative images from a few different sources, which are listed here at the bottom. The central cone is just showing a steepness right in the center. I personally think 1 and 3 are the most representative, this first one and then this one here, but this middle one is described as being, it is true, it's right there in the center. Oval or sagging is what I consider most common, which is going to be just the inferior depressed cone relative to the visual axis. And then global, which is going to be an overall steepening of almost the entire cornea from all the way from anterior to, or superior to inferior.
I have a question.
Yeah, please.
If we are monitoring an adult mild keratoconus or pellucid or some sort of corneal ectasia, a patient who sees well in glasses and soft contacts and just had refractive surgery ruled out but asymptomatic, how often would you advise performing topography for clinical care? Do you know how often insurance will be allowed to be billed?
Oh yeah, sure. So is that a patient with known keratoconus?
I think it's
Sounds like they're referred for refractive surgery maybe and diagnosed with keratoconus.
And just had refractive surgery ruled out, but asymptomatic. There's a concern for potential keratoconus or pellucid or some sort of ectasia. I don't know that they have a diagnosis.
Okay, no problem. Well, personally, I like to see these patients generally every 6 months. That's generally what I do for most patients in kind of like the normal age range. So I would consider 18 plus, usually every 6 months. Under 18, when these things can progress pretty fast. So if it is like a mild keratoconus, sometimes I consider as early as 3 to 4 months. And then as far as medical necessity, as long as you can document medical necessity, there really isn't any exclusion on how often you can perform topography, to my knowledge. So you want to do within standard of care, but I would say every 3 months, if you were really highly suspect, would be reasonable. Other questions?
I think that's it for now.
Okay. So I want to go back to this patient's topographies and then look at the staging and the types. So this is based on the mean central K, which I've highlighted here. It would be different on different maps, but the right eye falls under stage 1. And then the left eye falls under stage 2, but it's right there at the borderline of reaching stage 3 because it's kind of right there at the junction. Okay, and then these both have an oval shape with the anterior elevation showing that, but mainly the axial maps here. Okay, and then we'll just go over like rapid fire keratoconus staging examples. So this is what would be considered form fruste keratoconus. So this patient would still have good visual acuity corrected to 20/20, but we are starting to see a inferior elevation of the cornea, pretty apparent on the axial map. And then corneal thickness map here shows thinner than average. And then we are starting to see what would often be called, or what's called generally, a temporal hug, which is this. I'm tracing with my mouse. That is a sign of generally early keratoconus, which is that posterior elevation. But the patient still sees well. So this would be totally excluded from any corneal refractive surgery, but not needing treatment yet with cross-linking unless there was documented progression.
Nathan, I'm sorry to interrupt. I just want to make sure I don't know how to mute everyone, but there is a couple noises in the background. I just want to make sure we had them muted.
Okay. Yeah. I think I just muted you, but you can unmute yourself if you need to. So ultimately, the next stage would be stage 1. So this is a patient with mild keratoconus. It's a central type. If there's documented progression, this would be a good patient for corneal cross-linking. This patient would do pretty well in a lot of different modalities of contacts because the cornea itself is pretty not too terribly steep. It's 43.8, so it's really not that much outside of a normal, but obvious posterior elevation. Another example of mild, which is a oval type, still with the central K readings of less than 48, progressing to a moderate stage, which is a central K reading of less than 53. So we're looking at 52.5. A advanced, which is central K readings greater than 53. So we see more steepening both on the anterior surface, and then the elevation on the posterior surface becoming more pronounced. Still oval type. This is an example of global that falls under the stage 3. So the Ks on these are actually fairly similar, as you can tell, but this is just a different type of keratoconus, or different type of pattern. We're going even higher to the stage 4, which is severe. This is 62, and kind of a mix between an oval or a global pattern. And then a definitive severe Ks in the 70s, thickness in the low 300s, and a very global pattern. So that's just a rapid fire on some different presentations of keratoconus. There was a big paper published fairly recently, the Global Consensus on Keratocona and Ectatic Diseases. And if there's 2 or more of these things, then it shows progression, which is steepening of the anterior corneal surface, steepening of the posterior corneal surface, and then thinning or increase in the rate of corneal thickness change. So if there's documented thinning of the cornea. And then often used in clinical trials is a little bit more esoteric perhaps, but essentially if the steep or flat or mean Ks are increasing, it's evidence of progression. Also for insurance purposes, an increase in refractive astigmatism, usually greater than 1, I believe, and an increase in refractive myopia, usually greater than -50, shows evidence of progression that justifies corneal cross-linking. So if you don't have topography and you are following keratoconus patients, if they're progressing even in their refractive error, that information can be submitted to a referring doctor to justify cross-linking. All right, and then case 4, 33-year-old female who's interested in refractive surgery, fairly spherical, -4 refractive error, correcting to 20/20, average pachymetry. And so looking at this, you'd think, oh, this is a great patient for our standard refractive surgery like LASIK. However, if we look closely at the topography, we are seeing in inferior steepening pattern here, so that the bottom half of the map is steeper than the top half. It's pretty uniform between the eyes. Fortunately, there's no elevation on the back surface of the cornea. So that's an important thing to look at. Whenever we see this in our clinic, we normally don't do 2 topographers routinely, but we will repeat it, and it was repeatable on the Placido type. This was a Scheimflug type, and this is a Placido type. The important thing is this, the Scheimflug topographer does have an important analysis that looks at how the corneal thickness is changing from central to peripheral, and that's considered the percentage thickness increase. It's reflected in this map right here, and if the percentage thickness increase falls within the upper and the upper and lower bar, then the cornea is considered statistically normal. It's represented in the bottom right corner by what's called the D value, and generally a D value under 2 is our general cutoff for considering surgery. In the right eye, it's actually showing white, which is normal. In the left eye, it's showing yellow, which is caution, but not red, which would be out of normal range. So the facts on this case, there's mild steepening of the inferior cornea, but we feel is confident not keratoconus, several reasons. The patient sees 20/20. The pachymetry is pretty much within normal, this is the reflection on the map. The manual was showing 550s. The Berlin and Ambrosial analysis, which is reflected here, is within normal. There's no posterior elevation, which is the most important thing. So this would be controversial, I will say. Some surgeons would still not operate on this, but with stable refractive error, and these maps and this information, we sometimes feel PRK is appropriate. So this patient had PRK. They saw about 20/50 at 1 week, which is normal, and then the delayed healing, but 20/20 at 1 month. And the patient was co-managed with a local community doctor and very happy. Can't be billed, of course, because it's used for refractive surgery. And I do want to show a contrasting example, which would be a case of like mild keratoconus or forme fruste keratoconus. The maps potentially look somewhat similar. If you look at this upper one here, we see that inferior steepening. It's a little bit more pronounced here, but what we see on this one, which would be in elevation of the posterior surface, and then a significant outside of average change as the cornea progresses from central to peripheral, falling outside of normal limits, which is why this D value is being reflected in above 2. Ultimately, this immediately excludes the patient for refractive surgery, and in fact, they need to start to be monitored for keratoconus. All right, and case 5 is a 52-year-old female with prior LASIK. Their complaint is blurred distance vision. They are interested in enhancement. The refraction was stable over many visits, correcting to 20/20. Patient was very insistent they wanted an enhancement. This is minimal refractive error, and if they would have been happy with glasses or contacts, that would be great. But if they want the enhancement, we watch it. There's dry eye ruled out. We did perform an enhancement. This was their topography prior to the enhancement. Unfortunately, the enhancement was gone about by a relift, which is sometimes preferred because of the faster healing. Unfortunately, the patient went on to develop epithelial ingrowth, which was in the left eye, which resulted in blurred vision. The prescription of +2 axis of 62, which is important. On the topography, we see an area of flattening here over the ingrowth, and then it is somewhat subtle, but there is a fairly significant induction of astigmatism. So it's actually inducing 2.5 diopters of astigmatism, even though this map doesn't look too much. This is the values next door, 2.5, and it's in this meridian right around 62. So it's coincident with their refractive error. So because of this, even though the ingrowth looks pretty peripheral, which we see, we are pretty confident the ingrowth is causing the problem. So we did a relift and flap cleaning, and the vision improved. Important, this cannot be billed because it's used for refractive surgery. And then I have one more case, and then we'll take any other questions. 74-year-old male, blurred double vision and shadowing in the right eye greater than the left, diagnosed with cataracts. They had significant amount of astigmatism. Ultimately, these are the maps showing a significant elevation of the superior cornea, which is somewhat, the opposite of keratoconus, but just a very non-specific type irregularity. This is very classic for Salzmann's nodular degeneration. So showing that elevation of the superior cornea, induction of irregular astigmatism. We reviewed carefully with patient that cataracts are not the only cause of blurred vision. And then one big thing would be what to do. Do you use a monofocal lens? If the patient's happy with wearing glasses or contacts, then totally good. If the patient is highly motivated for spectacle independence, then superficial keratectomy or PTK, which is essentially the same thing done with the laser, should be considered, as that can normalize the cornea. And I almost stole Julianne's case, if anyone was in that Dr. Cook's case from earlier, because it showed a really beautiful before and after of Salzmann's that was treated with PTK. But ultimately, this can be billed with Salzmann's and irregular astigmatism as the diagnosis. And then my personal opinion on this much irregularity is probably a toric IOL is not a great idea. That's everything that I have. I appreciate everyone once again for making it. These are my references, and I'd be happy to stick around and answer questions even if we're beyond. And then if anyone has any questions about the event or anything at all, please feel free to stick around and I will stay until any are answered. Okay, but thank you again. We appreciate you taking the 1 to 5 hours or however much time you spent with us, and I wish you all the best of health and safety and happiness during this time. Thank you again.
No current questions, but I'll be looking for you.
Awesome. Great. Well, feel free to leave. You've all got your credits. And once again, I will stick around for a moment if there are any questions to answer them. I really appreciate everyone.